Now we are going to discuss about theories of growth. Why is it so important to know about how the growth occurs? Because malocclusion is not a pathology, it is a developmental problem. So in order to know the in and outs of a malocclusion, we need to understand how the growth occurs and what are the processes that control the growth of an individual. Let us look into the theories of growth. There are several theories proposed by several authors, of which few are genetic theory proposed by Brody, sutural dominance theory by Fisher, Melvin-Moss functional matrix hypothesis are the important ones. And apart from these theories, we also have a multifactorial theory proposed by Van Limborg, Hunter and Enlow's growth equivalent concept, and cybernetics proposed by Petrovic. We also have one more theory, that is Cartilaginous theory. Let us look into the pros and cons of these theories one by one. The first one is genetic theory. What the genetic theory says is, growth of an individual is a predetermined thing and every individual has a blueprint, a genetic blueprint that determines the pattern of the growth of an individual, magnitude of the growth of an individual, and all the variations occurring in the growth of a particular individual are subject to this blueprint. It's just an assumption. But this theory was not widely accepted because if this theory is a perfect one, then it would have been easy for every individual to assess the features or to predict the features of their offspring. Is it happening? No. So, genetics is not the only factor that determines the growth or that controls the growth of an individual. Apart from the genetics, there are also some environmental factors and epigenetic factors that control the growth of an individual. So, we can't take genetics as a whole and sole responsible aspect behind the growth of an individual. So, it is not accepted wholly. So, this is a contradicting point of genetic theory of growth and development. The next theory is sutural dominance theory proposed by Fisher. This theory says that sutures are the primary growth centers. Growth at the sutures or proliferation of the tissues at the sutures is responsible for growth of the craniofacial skeleton. This theory is also not widely accepted because several authors have done several experiments on to confirm the viability of this theory. What they did was, they created an artificial environment mimicking the biological aspects or simulating the biological aspects in a human being, and they have found that the sutures didn't have innate growth potential. Rather, we can say that this theory is not completely accepted. So, sutural dominance theory was not completely accepted because the sutures didn't show innate growth potential when they are cultivated in an artificial medium simulating the biological environment that is present in a human being. One more theory that explains the growth and development of individual is cartilaginous theory. This theory says that cartilages have innate growth potential. Growth at the cartilages is responsible for growth of the entire craniofacial skeleton. When we take the cartilage at the base of the skull and cartilage in the nasomaxillary region, that is nasal septal cartilage, these are the main cartilages that determine the growth of the nasomaxillary complex and the cranial base. These are the primary cartilage. The authors, what they did was, in order to check the viability of this theory, The others cultivated the cartilages in artificial medium, and they have found that two responses were elicited. The primary cartilage had innate growth potential, whereas the secondary cartilage did not grow on its own. So, this theory can be partly accepted and partly opposed, because primary cartilages are able to respond to the growth stimulus occurring in the body on their own, whereas secondary cartilages are also showing the growth potential but under the influence of local factors but not systemic factors. Here, when we take the septopremaxillary ligament along with nasal septal cartilage, determines the growth of the nasomaxillary complex. This is taken as nasal septal theory of craniofacial growth. So this is the image. You can clearly define the turbinates, the nasal septal cartilage, the alar cartilages, greater and lesser. These cartilages grow and in turn are responsible for growth of the nasomaxillary complex. Now, as I told you, there are two types of cartilages, primary cartilage and secondary cartilage. When we take the role of primary cartilage in growth of an individual, they appear first around 5th week of intrauterine life. Around 8th week of intrauterine life, the independent sites at the chondrocranium, that is the cranial base, nasal and otic structures, starts coalescing at around 8th week of intrauterine life. In the mid-childhood, the primary cartilage is entirely replaced by bone by process called as endochondral ossification. Primary cartilage thus has its own growth potential. It grows by interstitial growth and it is very much tolerant to pressure, flexible, avascular, and it does not require any nutrient supply. And the primary cartilage is genetically predisposed autonomous tissue which can be influenced directly by the hormones, which in turn influences the development of the craniofacial skeleton. Growth of the maxilla is controlled by nasal septal cartilage and it is the pacemaker of growth of the nasomaxillary complex. Even when we take a mandible, it is nothing but a long bone bent into a horseshoe shape with its ends that are condyles covered by the cartilage. But unlike the nasal septal cartilage, the cartilage covering the condyles is a secondary cartilage which is not influenced directly by the systemic factors like hormones. Rather, it is influenced mainly by the local growth modulators and local pressure responses. The next theory is Enlow's principle. There are two important principles proposed by Enlow. One is counterpart principle, the another one is V principle or expanding V principle, we call it as. Growth of any given facial or cranial part relates specifically to other structural and geometric counterparts in the face and cranium. That is, when we consider a craniofacial skeleton, each component of the bone has its own counterpart within the craniofacial skeleton, and the balanced growth of this part and counterpart will lead to a balanced development of craniofacial skeleton. That is what the Enlow's counterpart principle says. When we consider growth of maxilla and mandible, the bony maxillary arch lengthens horizontally by deposition of the bone in the region of tuberosity. Thereby, deposition occurs on posterior facing cortical surface of maxillary tuberosity. Resorption occurs within the maxillary sinus opposite the same side of the cortical plate, and as the maxillary tuberosity lengthens posteriorly, whole maxilla is displaced anteriorly. Now, the counterparts of the bony maxillary arch are upper part of nasomaxillary complex, anterior cranial fossa, the palate, and the corpus of the mandible. According to counterparts principle, if the growth of the maxilla and all these maxillary counterparts occurs in a hand-by-hand manner or occurs in a coordinated manner, then there won't be any craniofacial anomaly. If any deviation or any discoordination or any non-coordination between the maxilla and its related counterparts in the craniofacial skeleton occurs, then established dentofacial or craniofacial deformity will be ensuring or occurring. When you take a mandible, it is not a single functional element. It has a corpus or body and a ramus. Now, the ramus and the corpus are counterparts to each other within the mandible, and the mandibular body is counterpart to the maxillary body. That means the growth of the body of the mandible and the growth of the body of the maxilla should occur in coordinated manner to ensure a normal relationship between maxilla and mandible. In the same way, the growth of the ramus and the growth of the corpus of the mandible should occur in a coordinated manner to ensure the proper relationship of these two structures within the mandible, thereby eliminating any occurrence of a craniofacial deformity. Now, when we consider a nasomaxillary complex, deposition occurs on the inferior or oral side of the nasomaxillary complex, whereas resorption occurs on the superior or nasal side of the palate, which results in downward movement of the palate and downward movement of the alveolar ridges. As a whole, the maxilla will be displaced in a downward direction or inferiorly. So that is the counterpart principle. To put in a simple manner, craniofacial skeleton has different skeletal segments, and these skeletal segments have their own counterparts. The growth of these craniofacial skeletal segments and their counterparts, if occurs in a coordinated manner, then there won't be any craniofacial deformity. If these parts and counterparts grow in a non-coordinated manner, then it ensures a craniofacial deformity and a malocclusion. That is in a nutshell about Enlow's counterpart principle. Now, the next principle proposed by Enlow is expanding V principle. It is very useful and a basic concept. When we take different segments of the bony maxilla or mandible, the growth occurs in an expanding V manner. If you look into the image here, the resorption occurs on the inner side of the V and deposition occurs on the outer side of the V, and the growth movement occurs towards the wide ends of the V. This is Enlow's expanding V principle. This is how it occurs. When we consider a maxilla and relate its growth to the expanding V principle, resorption occurs on the superior surface of the maxilla and deposition occurs on the inner surface of the palate. That is, resorption on the nasal side of the palate and deposition on the oral side of the palate. As a result, the palate or the roof of the oral cavity will be shifting in a downward and a backward direction. The anterior part of the maxilla is subject to resorption on the labial side and deposition on the lingual side. When you take the palate, The nasal side of the palate undergoes resorption, whereas oral side will undergo deposition. Similarly, in a coronoid part of the maxilla or coronoid process of the maxilla and ramus of the mandible also, we can see a growth direction which mimics an Enlow's expanding V principle. The same thing we can see in the condyle also. Resorption on the outer side of the V and deposition on the inner side of the V, and the growth movement occurs towards the wide ends of the V. That was about Enlow's counterpart principle and expanding V principle. The next important theory of craniofacial growth is von Limburg's multifactorial theory. According to this theory, the growth is influenced by three kinds of factors: intrinsic factors, epigenetic factors, and environmental factors. Intrinsic factors are nothing but the genetic makeup of the portion that is growing by itself, whereas epigenetic factors can be further classified into local epigenetic factors and general epigenetic factors. Local epigenetic factors include the soft tissue matrices like eye, brain, and whatever the soft tissues that are present in the vicinity of the bone that is growing, whereas general epigenetic factors include the hormones. Now, the environmental factors can be further classified into local environmental factors and general environmental factors. Local environmental factors include factors like action of muscles or action of tendons that are closely attached to the bone whose growth is considered. Whereas general environmental factors include the climatic status, in which the individual is growing, availability of oxygen, nutrition, etc. So all these factors combinedly affect the growth and development of an individual, or specifically growth and development of the craniofacial skeleton. So the factors controlling the growth and development of an individual or the craniofacial skeleton are intrinsic genetic factors, local epigenetic factors, general epigenetic factors, local environmental factors, general environmental factors. So these are the 5 factors controlling the growth of an individual. That's why this theory is named as von Limburg's multifactorial theory. The next important theory that is widely accepted and clinically implicated is functional matrix theory or functional matrix hypothesis proposed by Professor Melvin Moss in the year 1962. This theory is exclusively based on the concept of functional cranial component proposed by van der Klaauw. Okay, now the functional matrix hypothesis states that the origin, growth, and maintenance of skeletal tissues and organs are always secondary, compensatory, and mechanically obligatory responses to temporally and operationally prior events and processes occurring in the related non-skeletal tissues, organs, and functioning spaces. The entire statement says is the growth of skeletal structures is always secondary, compensatory, and obligatory response to the growth of the adjacent soft tissues, functioning spaces, and organs. This theory states that there is no direct genetic influence and there is influence by embryonic functional matrices and non-osseous structures. Soft tissues grow first, later the bone and cartilage responds to the growth of the soft tissues. This is the statement of functional matrix hypothesis. Now, when we take the craniofacial skeleton, various functions are carried out in this area like digestion, respiration, olfaction, speech, balance, vision, okay, and hearing or audition we call it as. Each of these functions are carried out by a group of tissues. We call it as a functional cranial component. That means one functional cranial component carries out digestion, one functional cranial component carries out respiration, and so on. When we take a functional cranial component, it has two components in turn. One is functional matrix, another one is skeletal unit. Now, when we take a functional matrix, again it has two components in it. One is periosteal matrix, another one is capsular matrix. Now, what is a periosteal matrix, or what are the periosteal matrices? These are nothing but the structures, the non-osseous structures which are present adjacent to the bone and in close association with the bone. Growth of these periosteal matrices will lead to the transformation or change in the shape of the bone and size of the bone. For example, if we take a coronoid process, the periosteal matrix that is influencing the growth of the coronoid process is the tendon of temporalis muscle. Okay. Similarly, when we take a head of the condyle or neck of the condyle, the pterygoid fovea, the depression in the condylar region, it gives attachment to the lateral pterygoid muscle tendon. The growth of this tendon of the lateral pterygoid muscle will directly influence the growth of the neck of the condylar region. So this is how the growth of the periosteal matrices will cause direct transformation of the skeletal structure with which they are associated. Thereby, there will be change in the shape and size and morphology of the skeletal structures. Now, what are the capsular matrices? These are nothing but the spaces. These are the spaces surrounding the skeletal structures. We have four cranial capsules, that is neurocranial capsule, orofacial capsule, otic capsule, and orbital capsule. Now, a skeletal structure is encased or sandwiched in a capsule. When we take a neurocranial capsule, the calvarium is surrounded or encased by this neurocranial capsule, which has a outer covering of the scalp and the inner covering by layers of the dura mater. In between these two layers is a calvarium. Now, growth of this neurocranial capsule will lead to the more space or more room is provided into which the growing calvarium will translocate or shift into the spaces that are provided by the growth of this neurocranial capsule. Similar is the case with orofacial capsule. It is nothing but the skin and mucosa that surrounds the skeletal structures in the oronasopharyngeal region. Increase in the size of the capsule will lead to passive movement of the functional cranial component and compensatory transformation of the skeletal unit, thereby growth occurs. So, a functional cranial component has a skeletal unit and the functional matrices. The functional matrices are capsular matrix and periosteal matrix. Capsular matrix is nothing but the encasing capsule, that is skin and mucosa or the skin and dura mater, whatever it is, depending upon the skeletal structure which it encases. The growth of the capsular matrix will lead to more availability of the room into which the growing bone can translocate or changes its position, whereas the growth of the periosteal matrices will cause direct transformation and change in the morphology of the bone. Now, we have one more unit of functional cranial component, that is skeletal unit. This is nothing but the bone which ultimately responds to the growth of this capsular matrix and periosteal matrix. When you take the bone, again it is divided into a microskeletal unit and macroskeletal unit. A macroskeletal unit is nothing but a big bone which is involved in a particular function, whereas the microskeletal unit is a portion of this big bone which can be involved in the function apart from the function carried out by macroskeletal unit. For example, if we take a mandible, the entire mandible can be taken as a macroskeletal unit, whereas within the mandible we have the condylar region, the condyle, the coronoid, the genial tubercles, okay, and the fossa that encases the gland, the mandibular gland, okay, and the mylohyoid ridge. These are the microskeletal units. That means each microskeletal unit can be involved in multiple functions, and a confluence of microskeletal units will give a macroskeletal unit. Got it? Here is a orbital capsule. The orbital mass is surrounded by the supporting tissues of the eye. Any enlarged eye or small eye will cause a change in the size of the orbital cavity. Here, the eye is the functional matrix. Similarly, we have a orofacial capsule and neurocranial capsule that I have explained to you prior. Now, when we take a skeletal unit, it is composed of bone, cartilage and tendons of the muscles that are attached to the bone. What is a macroskeletal unit? It's nothing but an adjoining portions of number of neighboring bones carrying out a single function is taken as a macroskeletal unit. For example, when we take the endocranial surface or of the cranial base, here we have number of bones like ethmoid, vomer, sphenoid bone, okay, portions of occipital, parietal and temporal bones. So, entire cranial base is formed by a component parts of different bones. Now, these component parts of different bones forming a large component carrying out a function. Here, the function of the cranial base is holding the brain. Now, this is called as a macroskeletal units. Okay. Now, what is a microskeletal unit? For example, if you consider a maxilla has an orbital surface that houses the eyeball and a pneumatic space, that is the sinus, that carries out a function, and the parietal portion and the basal bone. So these are different microskeletal units of a big bone, that is maxilla. Similarly, when we consider a mandible, we have a different small skeletal structures like coronoid process, angular process, alveolar process and basal process of the mandible, which are microskeletal units of the mandible. So, these are the different theories that were proposed by different authors. Of all these theories, now the most commonly accepted and clinically applicable theory with respect to the orthodontic functional appliances is functional matrix hypothesis. Okay, so it is important for a clinician to know how the growth of an individual is controlled, so that we can clearly point out where the problem has occurred during the process of development, and clearly we can institute or we can perform our treatment or any clinical procedure with utmost care, so that the problem is addressed and the solution is evolved and we will reach at a good treatment result. So that's why it is very much essential for us to know the theories of growth and development. Okay, now orthodontic treatment irrespective of appliance depends to a great extent on the adaptive capacity of alveolar process, growth and remodeling. That is why it is always essential to know each and every aspect of growth and development in order to successfully treat a established dentofacial or craniofacial deformity. Thank you.